Good morning and welcome to a special program here on the Talk of the Town, 1590 KBGB. My name is Scott Donovan, and today we've got a very special guest with us. We're going to be talking about some very important information. As a matter of fact, we would like to welcome, first of all, Ken Johnson, the interim president and CEO of Hutchinson Regional Healthcare System. Good morning, Ken.
Good morning. Thank you.
Yeah, and you brought a special guest along today.
I did. I brought with me Dr. Mike Hagley. Dr. Hagley went to the School of Medicine in the University of Nebraska College of Medicine in Omaha. Did his residence training at Washington University Medical Center in St. Louis, and he is currently our medical director for our cardiovascular program for the cath lab. He's a physician that's on staff at Hutchinson Clinic and has been there since 2002.
Well, very good. We welcome you to the show.
Thank you. It's great to be here.
And I know that recently you had the opportunity to speak with the Great Bend Rotary Club and talk about a lot of the things that we're going to be visiting with today. So tell us a little bit about some things that people should know about Hutchinson Regional and what you guys are doing there, and especially your expertise, Doc.
Okay. Well, first, I was really excited to come up and speak with the Rotary Club here.
Yeah.
It was a great group of people, and I've always had a lot of respect for the medical community in Great Bend and the things that have happened here over the time I've been in Kansas. So it was a real pleasure to come up and, be invited into the community and talk about what we do.
And we should mention, too, that there's a guy that really made this happen, this interview today, and it's Richard Shank, and he happens to be sitting over here in the corner.
Absolutely. we won't let him talk.
Yeah, he's not much of a guy to be on radio, I will tell you that. But he did give me a call, and he said, Scott, he said, hey, that you were going to be in town, and we wanted to set aside some time and visit with you about it. Because what we want to talk about here, a lot of things. First of all, heart attacks, and maybe how some of them could be prevented, right?
Sure.
Yeah.
It's always better to prevent it than treat it. So
That's true. And as you are a nationally known cardiologist, as we mentioned, and it goes without saying that you are an expert on a specific kind of thing that we want to talk about today. And I'm going to go ahead and let you hop right in.
Well, I'll just talk a little bit about sort of my training path that I took.
Okay.
When I finished my medicine residency, I went on to cardiology training, which was at Washington University Medical Center in St. Louis. And I learned how to sequence DNA there, too, because it's a very basic science-oriented place. But in my cardiology training, I got good experience doing heart caths and balloon angioplasty and things of that sort. But I realized that one thing that I lacked there was the opportunity to take care of peripheral arterial disease, or PAD, that you might hear about or read in the paper. And there weren't very many cardiology programs at that time offering training in peripheral arterial disease treatment, but there were several interventional fellowships that did. And so for my last year of training, I went to Houma, Louisiana, to the Cardiovascular Institute of the South, which was really one of the very busy, aggressive places in treating peripheral arterial disease.
Wow.
And I went there knowing that I would have my tail worked off.
Yeah.
The time I was there, I did about 1,700 cases
Oh,
in a
my
year there.
Goodness.
But I got...
In a year's time?
In 1 year.
Oh, my gosh, Doc, that's a lot.
So it was kind of night and day, but I got what at that time would have been state-of-the-art training and evaluation and treatment of peripheral arterial disease. Now, what we do today is really, in most respects, very different from what we did then. But it served as a terrific foundation or springboard for learning the techniques that have come along subsequently and being able to incorporate those into my practice.
And I would guess that, practice makes perfect. I mean, obviously, if you're doing 1,700 a year at that point in time, that's a lot of work.
Yeah, I was pretty comfortable, and, you can, this is an example of why a work ethic is important. I mean, you could get through a training program and do far fewer cases. Some people will do 150 or 200 cases in a year, and they have lots of time to sit around and read.
Right.
But I wanted to have a lot of cases under my belt, and I felt very capable and very well prepared for the real world, even 6 months into my training program.
Ken, do you still have him working that hard today?
He works very hard.
1,700 a year.
Very busy.
That's incredible to me. Now, what's so special about this peripheral arterial. You go ahead and say it again.
PAD.
Thank you.
Let's make it easy.
I'm a radio guy. I appreciate that. So, there are a lot of people that suffer from PAD.
There are. And really, if you have blockage in the arteries of your heart,
right,
you're going to have it in your legs too. It's not a matter of whether or not you have it. It's going to be a matter of whether or not it's producing problems for you.
And when you're going to notice it.
Right. And so we treat it once it produces symptoms. And the symptoms that people get will sometimes be pain. And the pain usually is pain that occurs in the calf muscle when they walk. And it gets better when they rest. So that's kind of the pattern that I look for to know that somebody has a blockage that's significant. The other manifestation you may see as well is ulceration on the foot or pain at rest.
Mm-hmm.
And that's a little different category, one that we call critical limb ischemia, or, it's a critical problem that portends a high risk of limb loss.
Wow.
So I typically treat patients for one of those two reasons.
So what we're finding out, though, with these numbers that were given to me, which I want to share to all of our listeners out there, 8 million Americans suffer from PAD, or around that, and 1 out of every 3 people over the age of 50 with diabetes, because that's a big part of this, may have PAD. And really, it affects anybody, but you're really talking to folks maybe 65 and over for the most part.
Right. It's a problem that's associated with age.
Uh-huh.
And then the other risk factors, big risk factors for this, are diabetes and cigarette smoking.
Okay.
So now cholesterol, family history, things of that sort contribute as well. But the really strong predictive factors are diabetes, cigarette smoking, and age.
How about high blood pressure?
Again,
a
it's
little bit
a
of
contributor,
yeah,
but not so much to disease in the legs. It's more of a predictor of stroke risk.
And Doc, when people say, "Hey, you know what? I used to smoke, but I quit 5 years ago," hey, they're still in that
You see
lineup, right?
Well, you see a pretty quick reduction in risk of certain events when people quit smoking. But once the disease is established, hopefully people quit smoking, but you still have to deal with the disease that's there.
Right.
And so, yeah, they may continue to have problems.
So, I know we're talking about a buildup that really causes the arteries to narrow and obviously, limits the blood flow to legs. When do you really notice it to be a constant thing? Do you have to wait that long? Do these come in segments? Is it something you're going to notice almost every time you do an activity that maybe overdoing it?
It tends to be a pretty consistent pattern where people will have pain in the calf muscles or calf muscle when they walk, and it resolves with rest. Now, it may occur a little bit more quickly, or with a shorter distance if they're going up steps or up a hill or walking quickly. It may take a little bit longer if they walk slowly or on level ground. But the pattern's typically pretty consistent. And treating it isn't going to reduce mortality risk or anything like that.
Right.
You treat it with an interventional procedure to improve the quality of life so that people can function without having symptoms. And so I like to see somebody who has symptoms that are interfering with their lifestyle in some way.
Right.
And those are the people we can help restore to a more active lifestyle.
And you're talking about pain that is so strong that it will literally make them stop what they're doing.
Most people will stop. It depends, of course, on a person's pain threshold.
Sure, yeah.
But
yeah. And that probably grows throughout this disease, I would imagine, unfortunately.
Most people will get to a point where they can walk a block or less, and
Ooh.
they get tired of that. They have to stop in order to get relief from the pain. And so the other feature that people will oftentimes report, in addition to the pain, is really profound fatigue in the affected leg. And so, again, that interferes with pushing through it.
How about something like cold feet or something like that? Is that also a problem?
Well, yes and no.
Okay.
People with this problem may develop cold feet, and so sometimes that's a presenting symptom, and we need to treat it. But the vast majority of times when people have cold feet, it's not because of peripheral arterial disease. It's because they're getting older and their skin's getting thinner.
I get you.
And your hands and your feet get cold before the rest of you.
That's right.
And it's because you have more surface area for the volume of tissue there. It's sort of the thing that we all understand intuitively after our childhood, the reason why mittens are warmer than gloves, because you have less exposed surface area.
That's true.
So the hands and the feet get colder as time goes on just because the skin's thinner and you lose heat there.
Okay. So it really doesn't deal with that per se, but that can also
It can
play into it, yeah.
But, sometimes I'll see a person who's referred with cold feet, and I check, and the pulses are terrific. There's great circulation there. It's just that they're getting older and the skin's getting thinner, and I wish I could help, but I can't.
And sometimes I'm sure that these folks say, I just have cold feet about having this procedure done, which is a whole different story.
Oftentimes, and I don't blame them.
That's a whole different thing there. Well, I think it's quite interesting. And what you're talking about is a procedure that could really change their lifestyle, help them out in the long run. And tell us a little bit about the procedure that we're talking about with PAD.
Well, what we do depends on where they're blocked, but I'm going to go with the most common problem, which is a blockage in the artery in the thigh, which is called the superficial femoral artery, or we like abbreviations here. We'll just call it the SFA.
Thank goodness for you. Yes,
SFA. So when we're treating that artery, you would think because stents work well in the heart that they ought to work well in that artery, but they actually don't.
Right.
Stenting that artery is full of problems because that artery has to twist and turn and change length and do things that a metal stent can't do very well.
And your heart pretty much stays stable in its
Exactly.
position. You're not exactly moving that around a whole lot.
Exactly. So we've, for the most part, most of us have got away from putting stents in that artery, and those who haven't got away from it should.
Yeah.
So the more likely approach that people have been taking recently is some sort of an atherectomy or a procedure to remove tissue that's blocking that artery. And we have two catheters we use in Hutchinson. One is a directional atherectomy, or a silver hawk catheter, that allows us to go through the narrowing and actually trim out strips of tissue and restore a normal lumen. The other one that we use now is a device called a diamondback, which is a diamond-coated burr or crown that rotates at 80 to 100, rather to 120,000 RPMs.
Oh my God.
And allows us to go through and grind that artery out. That catheter works better for the really hard calcified arteries.
Right.
But the best innovation that's come along is sort of a treatment after we've done those things. In the past, in the arteries on the heart, we started putting medication on stents to prevent renarrowing. And what we do now in the peripheral arteries is we have balloons that are coated with medication to prevent renarrowing. When you dilate an artery, the body responds to that. You destroy or injure some elements of the artery. And if this was a few years, 10,000 years ago, and you'd been bitten by a bear or a saber-toothed tiger, and it punctured your artery, your body has to respond with a healing process.
Right.
And sometimes when we treat that artery with a balloon now, that healing process is a little bit too vigorous. So we can give a medication to tame that and avoid forming scar or tissue inside of the artery. And we actually can get, with the balloons that we have now with medication, 2 years out, we can have about a 91% freedom from repeat treatment.
Wow, that's just what I was going to ask you, because that's got to be a big part of this when it's not done correctly or done, and I'm sure the procedure itself doesn't take that long, does it? Or something that people will heal from rather quickly?
Well, it depends. Again, if it's just a short narrowing and it's not a total occlusion,
right,
I can get in and do those very fast. But we'll sometimes treat people who have 20 or 30 centimeter total occlusions, and we have to recanalize that whole thing.
Oh, wow.
And that can take a lot more time. To me, this has always been something that was exceptionally interesting and gratifying to treat.
Right.
And so I don't mind taking the extra time to do that. It's kind of fun, and it's neat for me to realize that I have an ability in that department that's kind of uncommon, and I feel like I have an important obligation to treat people who need that treatment.
I think that's incredible. How special is this, Ken, nationwide? Let's talk a little bit about that and what you guys are doing at Hutchinson Regional Medical Center.
Well, the thing that I will say, and now Dr. Hagley can describe some of the technology, but with his leadership and as skilled as he is, he's very innovative and leads our cath team in looking at new technology. Frequently, we've had the opportunity to host some pretty skilled physicians that are nationally known and have been involved in developing some of the products that were used in the beginning of the cardiovascular or the cath lab medicine. And so we're very fortunate to have Dr. Hagley, who's very attuned to technology and very innovative. He's a very good educator. Mm-hmm. The team that he has are very skilled, and they enjoy working together, and they're just a great team.
I would imagine if you explain this procedure with somebody that's having this kind of problem, that it seems pretty simple to me. Just you talking about it right now. But we know that it's a lot more defined than that.
Well, it is, and it isn't simple. Uh-huh. When I'm telling people what they really want to hear is we're going to go in and we'll identify the area that's blocked and we'll trim it out and get you treated.
Yeah.
And you'll be able to go home in 4 hours. And, wow. And that's pretty good news.
Yeah.
If you know how to do it, then you learn how to make it simple. If you don't know how to do it, then you can make it very complicated.
That's right.
So I want to go back to what Ken was saying, and this has been a real collaborative effort. We've been very fortunate in our cardiac cath lab to have state-of-the-art technology and to have some of the newest and greatest innovations available early on. Mm-hmm. With regard to these drug-coated balloons, we were actually involved in using those before they were FDA approved as part of clinical trials and registries that the FDA evaluated to ultimately approve the technology. Mm-hmm. And so you can't do that sort of thing unless you have institutional support. And we have a research nurse and we have a cath lab that's dedicated to learning new things and trying new things. And so, leadership comes in part from the physicians, but it comes from the hospital side of things as well. That's
true. You got to have somebody that wants to invest in the procedure and make sure it's going to work. When you say these, balloons, I mean, just in everybody's mind, they're thinking of the balloons that you would blow up at a birthday party. Right. Explain a little bit about the size of these. I mean, obviously, you're talking about very intricate work.
Yeah, these balloons are smaller. We have balloons for the arteries in the periphery that may vary between 1.5 millimeters and 10 millimeters or 12 millimeters in diameter when they're blown up in various lengths. The materials are different. The balloons that you blow up at a party tend to be pretty compliant. That is, as you put more pressure in them, they get bigger.
Right.
Or as you put more volume in them, they get bigger. Our balloons tend to not grow that much, so as you put volume in them, the pressure goes up. Ah. And so we work at pressures usually anywhere between about 5 and 20 atmospheres of pressure. Now, an atmosphere of pressure is like having 33 feet of water on top of you.
Oh, my gosh.
So you understand that if we're at 10 atmospheres, that's like diving to a depth of 330 feet in the ocean. That's a lot of water pressure.
It is.
So these balloons are very robust and hold up under really high stress situations.
Mm-hmm. And the medicated balloons, I mean, just that part alone has got to be a pretty big investment into this whole thing.
Yeah, the trick with the medication is that the medication doesn't cross into the tissue by itself.
Oh.
So the trick was to get the medication on what's called a carrier molecule that will carry it across the cell membranes into the tissue in the artery.
Where it's needed the most.
And so that's the research prior to human trials wasn't so much on the medication as it was the carrier molecules.
Wow.
And there are two different companies that make these balloons with the same medication but with different carrier molecules.
That's fascinating. It really is. And when we talk about PAD, is it with one leg? Is it with two legs? I mean, how long would that procedure actually take if it was just, you said 4 hours, but is that for the...
Well, the procedure is much quicker than that.
Sure.
I mean, my procedures usually last between 30 minutes and a couple of hours.
Right.
It's 4 hours of recovery usually before people go home.
Right.
We don't try to tackle too much at one time, so it would be unusual to treat two separate legs at the same time.
Yeah. Sometimes
it just doesn't work because of the way you approach these problems. You're pointed in the wrong direction to treat one leg, so you treat the one you can. Of course, you can have a scenario where only one leg is involved, and in that case, you only treat one leg.
That's true, too.
You're not going to treat something that's not there. However, having said that, the arteries in the periphery tend to show a remarkable tendency to have symmetry. So if you have a lesion at one point in your left leg,
Mm-hmm.
the odds are pretty good you're going to have a similar lesion in your right leg.
Almost the same position.
Yep.
Same place. That's interesting. Very interesting. We're visiting with Dr. Hagley today from Hutchinson Regional Medical Center. We've got about 10 minutes left in the show or so, but Ken, I wanted to ask you as well, is this something that a lot of insurance companies are looking at as preventative and something that they're behind in this PAD procedure?
Well, I think where healthcare is going is preventative. You've heard many people talk about population health, and today we're still primarily reimbursed for the procedure itself or addressing those symptoms. We certainly, through education and developing programs within the hospital and within our communities, are moving more towards the preventative side to keep people out of the facility as opposed to letting them get sick, take care of them, and meeting those needs.
Yeah. Now, go ahead, Doc.
Well, with what we do as cardiologists, we think a lot in terms of primary prevention and secondary prevention.
Okay.
So primary prevention would mean you've never had a problem. What do we do to prevent problems? And that's kind of a difficult task because you have to identify a high-risk group in order to show any benefit.
That's true.
Once you've had a problem, secondary prevention becomes a much easier task. So we know somebody with blocked arteries in the legs or in the heart is likely to have problems again down the road. And once we know that, we treat those people with aspirin and with a statin to lower cholesterol. And we refer to that as secondary prevention. They've already had one event. We want to prevent the next event. And you can have a remarkable impact on risk of strokes, heart attacks, and death by treating people's risk factors aggressively.
Yeah. And you had mentioned earlier, one of the things that obviously you're trying to prevent is a foot or leg amputation.
Yes.
And I have some interesting facts here that were brought to my attention before this interview that approximately 160,000 Americans undergo that amputation annually.
Well,
and that's a game changer in somebody's lifestyle. I mean, that is really something that when you think about it, if you can prevent it, let's do it.
It's more than a game changer. It's a predictor of mortality.
Yes.
About a 30 to 50% 6-month mortality after an amputation.
Oh, my.
It's a predictor of a huge amount of expense to make the adaptations that are needed for that person to go on functioning. And so, we struggle, as an example, with arteries re-narrowing or with progression of disease. And people sometimes have to come in for repeat treatments or treatments of new problems. But I always tell them, well, wouldn't you rather undergo 3 or 4 or 5 different treatments for this than one amputation?
That's right.
And the answer is a resounding yes. And I'll tell you the thing that really irks me and makes me angry is that over half of the people who have amputations in this country for poor circulation don't have an arteriogram prior to the amputation. That is to say, the amputation is considered the primary treatment for their problem. Now, in my world, amputation is never the primary treatment for a problem. Amputation is a treatment failure. You've tried and it didn't work.
Yeah.
So a lot of my work is directed toward preventing amputations, and I get referrals for people who have ulcers on their toes or sores that won't heal, and they get referred to me, and oftentimes we can just promote healing. And then other times what we can do is convert what would have been a major tissue loss, like a below-knee amputation, to loss of a toe or a forefoot.
Oh, my gosh.
So those sorts of interventions can make a big difference in the lives of the people who are affected. In order to do that, however, you have to have experience and be willing to work in the small arteries below the knee, really down into the foot, so that you can restore straight line circulation to the feet and the toes.
And that's why this procedure is so special and so different, I would imagine, because you're probably the only one that goes to those areas, I would imagine.
Well, it's not common.
If needed. Right.
Yeah, I mean,
there you go.
There are people around the country who do this sort of work, but it used to be that there was a real reluctance to do much work below the knee. And the reason is that there are tight tissue compartments there, and people are concerned about perforating arteries and having pressure build up in those compartments. It's called a compartment syndrome. And so during my formal training, it was pretty uncommon and very nerve-wracking to go down there and work. And we sort of looked at it like sailing west from Europe a few hundred years ago. You know, we were asking, are we going to sail off the edge of the earth?
Right.
But as time has gone on, we've come to realize that, no, that's not really a big practical problem. And unless you restore straight-line circulation, it's probably not going to preserve that limb.
Right.
For me, as I was practicing, I actually went to Italy and worked with a cardiologist in Brescia, Italy, a guy named Lanfraud Graziani, who had been doing this sort of below-knee limb salvage work since the 1980s.
Oh, my goodness.
And went over to get an idea just how aggressive he was able to be, and then brought that back with me to try to use in our cath lab here, and it's really made a big difference in the way we approach critical limb ischemia.
Well, congratulations. That is just incredible to me, and you can tell that you've had a lot of experience. And this is something that people may want to know more about. And, Ken, that's where I come to you and ask you, how can folks find out more? How can they make an appointment? I mean, obviously, is there a referral thing for most folks out there? Is that how this works? Tell us about that.
Sure. Certainly, if you need more information, they can visit our website, and there's information there, hutchregional.com. And if call the hospital, we can certainly get you hooked up with Dr. Hagley and any of his team. Hutchinson Clinic is where Dr. Hagley practices his daily practice when he's not in the cath lab. And so they can get a hold of him there through their family practice physician and other physician that would probably make a referral as well.
Yeah.
Yeah, I would second what Ken's saying, that oftentimes it's the physicians who call us, but we're happy to see people who just call the office and make an appointment as well.
Make it real simple that way.
Yep.
And the other part of that, just go through the symptoms again. Go through what people may be feeling if they really think they've got a problem with PAD.
Well, oftentimes what they'll feel is either pain or fatigue or discomfort or pressure in the calf muscle that occurs with walking, especially if they walk faster up a hill, and it improves with rest. And so that's the main symptom. The other symptom that you'll see in a large portion of people is either pain in the foot or toes at rest, blue discoloration, or ulceration on the foot or the toes. Mm-hmm. So all those things are signs that you ought to have this looked into. Now, your primary care physician can do CAT scans or ultrasounds or things to sort of narrow the problem down a little bit. And so oftentimes people come to me with some preliminary evaluation already done, which makes my work in the office a lot easier.
Yeah. Does the size of person matter? The weight, does that sometimes play into what we're talking about too?
The weight factor
overweight
is because it correlates with presence of diabetes.
I understand.
So the people who, I mean, if it was all muscle, then the weight doesn't matter. But if it's fat weight, then the risk of diabetes will be higher. And if the risk of diabetes is higher, then there's more likely to be peripheral arterial disease.
And how does smoking come into play on that whole thing?
Well, smoking injures arteries in a lot of different ways. And again, it's one of the two really strong risk factors for peripheral arterial disease and for critical peripheral arterial disease.
Yeah. Oh, that's interesting. Dr. Hagley, thank you so much for your time today.
Thanks for having us.
We appreciate it. And Ken, it's always a pleasure. Thank you so much.
Thank you very much.
And Richard just waved everybody on the radio. We do that? I appreciate that. Thank you very much. Hey, it's been a very special Out and About program here. If you want to find out more, go to that website. Give me that website address one more time, Ken.
HutchRegional.com.
All right, check it out. Thank you so much for being here today. Stick around. We've got ABC News on the way next, and a look at your forecast here coming up in just a few on 1590 KBGB. Great Bend, the talk of the town.